The airways undergo approximately 23 orders of branching from the trachea to the alveoli. Each branching level introduces changes in diameter, wall composition, and function. And this progressive specialization allows the respiratory system to balance efficient airflow with maximal surface area for gas exchange. The trachea divides into right and left primary bronchi, which then branch into secondary or lobar bronchi, three on the right and two on the left. This asymmetry reflects lung anatomy and cardiac positioning. These bronchi continue to branch into segmental bronchi, each serving a discrete bronchopulmonary segment. Bronchopulmonary segments are anatomically and functionally distinct units, each supplied by its own bronchus and its own blood vessels. Connective tissue, septa, will separate segments, limiting the spread of infection or even malignancy. This segmentation of the lungs allows surgeons to remove diseased portions of the lung without compromising surrounding tissue, which is a critical concept in thoracic surgery. As airways start to narrow from the bronchi to the bronchioles, cartilage support will decrease and eventually disappear. This is then replaced by elastic fibers. The epithelium will transition from pseudostratified columnar to simple cuboidal, and goblet cells become more and more sparse. Smooth muscle starts to become increasingly prominent, allowing for bronchioles to regulate airflow resistance, which is a key site of pathology in asthma. Looking closer at the histology of bronchi, bronchial histology initially will resemble the trachea, and it will then change progressively with branching. Cartilage becomes discontinuous plates rather than rings, and smooth muscle layers become more defined. These adaptations allow the airways to remain open while still permitting dynamic control of airflow. And how you read this image is this is representing like this level would represent the trachea here, and then this level is showing kind of the primary bronchi, and this is going like branching further and further and further. And then once we're in this respiratory system here, this is really our alveoli. And so we can see like, you have height of epithelium becomes more and more flattened, goblet cells become less and less, club cells start to show up towards the end, ciliated cells less and less, glands less and less, et cetera, et cetera. So that's how you would read this image here on this slide. When we think of the goblet cells, as they start to disappear, they were replaced by, as I mentioned, these club cells, which is represented here in orange. These secrete different substances than goblet cells. Goblet cells are infamous for secreting mucus. Club cells secrete a surfactant-like substance, as well as detoxifying enzymes. This shift will reflect a decreased reliance on mucus and an increased emphasis on maintaining airway patency, so keeping the airways open, as well as epithelial integrity in these smaller airways, these smaller passageways. As we move more distally, smooth muscle becomes dominant, the dominant structural regulator of airway caliber. Our elastic fibers are present throughout the airway wall. They're essential for passive expiration because when we exhale, it's a passive process. When we have loss of elastic recoil, this happens in conditions like emphysema. This can compromise our ability to expire or compromises our expiratory flow of air, even if the airway is remaining open. So this balance between smooth muscle tone and elastic recoil is really important for normal ventilation. On that note, here's a discussion question for us to consider. Airborne particles that are greater than 10 micrometers in diameter tend to be trapped in the nose and upper airways and cleared relatively easily by mucociliary clearance. Particulate matter less than 10 micrometers can get into the bronchioles. Particulate matter less than 2.5 micrometers can actually get into the respiratory zone of the lungs. So explain why the smaller the particle size, the more dangerous it is for respiratory health. You can think about that for a second. But really, particle size determines how deeply inhaled material penetrates the respiratory tract. So larger particles become trapped by nasal hairs, our mucociliary clearance mechanisms, while smaller particles can get into the bronchioles and even the respiratory zone, like our alveoli. This is where our clearance mechanisms actually are severely inhibited and limited. So the particles that can get into those smaller zones, they can directly interact with our alveoli or alveolar epithelium, as well as macrophages, which promotes inflammation. And when we have inflammation, we can see things like oxidative stress and even then leading to longer term cardiopulmonary diseases. So this explains kind of the epidemiologic links between air pollution and mortality. More particulates that we breathe in that are smaller that can get further into our lungs, the more likely we are to see those environmental factors affect our respiratory system. So as we move on, we're going to start to transition now from our conduction zone or conducting zone, which is moving air, to next the respiratory zone, where gas exchange is occurring. And from here forward, every structure we discuss directly influences oxygen and carbon dioxide diffusion throughout the body.